with no further ado, I will take you through this program we have on post-traumatic growth today. So post-traumatic growth is the type of positive psychological growth that you get from struggling with an adverse event and being able to grow through that event. It doesn't minimize the struggle, it doesn't minimize the event or the trauma, but there can be some silver linings in that we can not only be resilient to get back to our baseline, back to where we were, but that there's some potential to move beyond that and to be stronger and better for it, for having had struggled successfully with adverse conditions. This is a mural that you may have seen in the media, a mural in Australia. So these photos that we have here from Yale New Haven Hospital, and here when we see these signs go up, it says, please do not cut through. There's no shortcuts in facing a pandemic. There's nothing we could have done once it was upon us, and we rose to the occasion and we faced this very challenging, scary at the beginning. It was quite scary. Everything closed down. Work-life integration was very difficult, and there was no shortcut. We had to pass through this experience. And so what can we do with this? Here is a depiction of what happens with a stressful event, an acute stressful event. We start with, there's been some baseline burnout that we started with that has been documented prior to the pandemic. So we had some baseline. We first were impacted by the pandemic, and we all had our adrenaline kick in, and we did our best to rise to the occasion, and we talked about the healthcare heroes, and we all were very together. We had the social cohesion, and we did this together. And as it went on, you know, people got tired. It took a lot out of us. The volume was high. It was some families. Many were doing homeschooling. Many were caring for elderly that they couldn't see or be directly with. Families were separated due to the risks of the pandemic, and it can be it can wear on people. To be aware that these are the events, these triggering events. When we get another stressor, when our reserves are low and we get another trigger event or another stressor, that's when we have to watch out, because these can really tip us over. And we have to be self-aware, and we do the Yale Stress Self-Assessment Pulse Survey to help people become self-aware of their stress symptoms so that they can tell, oh, I am feeling stressed, I'm coping with it well, I need to do, or not well, and I need to do something more about it. Maladaptive stress response would be when we start to detach and we withdraw and we try to reserve our resources, but we may be even more depleting if we withdraw from everyone else, we isolate ourselves or feel like we're starting to get depersonalized. When we disengage, maybe we have denial, maybe we occupy ourselves with different types of distractions instead of facing it. We may feel angry or irritable. Sometimes this can be times of relationship breakdown where we feel blame or anger, substance abuse. So we need to be self-aware of our stress levels and find out what we're doing. And then we have the option to also think, how can I seek help? How can I engage with others instead of withdrawing? Can I be more engaged? And can I be open to looking for role models and different ways of coping? And how can I move through this? And we'll talk about post-traumatic growth. But importantly, you don't want to feel pressure to begin a path or exploration of post-traumatic growth before you're ready. In this phase here, you may need to seek out psychologic first aid, acute mental health care, just to get through this acute phase. Then there may be a time where you're feeling some grief, where you're feeling fatigued, and maybe things weren't as you expected them to be for the year 2020 or 2021. And you have some real disappointments, and that's okay. You can be self-compassionate with yourself and have some time to grieve. And then as you're ready, you can think about how do I move into post-traumatic growth? Post-traumatic growth often happens in a situation where you are shaken to the foundation to the extent that it makes you question your priorities and your values, and it makes you question about how secure you are. You may feel out of control. And under those circumstances, you have stress. Sometimes that stress can lead to things like PTSD or these withdrawing symptoms or depression and things like that. And sometimes that stress can be used as a source of learning. And so that's what we're going to talk about, how we would use that potentially to help us to get to where we want to be, so that we not only recover to baseline, but we move beyond the baseline. And we are now here at the anniversary. So a lot of people are reflecting on the year that we've had, and people are looking for how do we move forward. So this can be a triggering time, and it can also be a time where we reassess and we move forward into growth, and we move through grieving and adjusting and come together as a community again in a new way, rethinking and reimagining what we want from healthcare. So who's driving? This question is stress. Who's driving the stress? Is stress driving you, where your perseverations or ruminations or the things that you're thinking about, is it interrupting your day? Is it intruding on your day? Is it driving you, or is there an opportunity for you to drive it? And that's one of the traits of how we think we can facilitate post-traumatic growth, is by using this to deliberately lean into those thoughts and those stresses and say, why do I feel stress? And to use it to drive you into the answers and drive you into reevaluating things so that you can move into your values and your priorities and beyond self, to move into this new space where you've actually learned and grew from having to struggle with this. And so we want to think about what's happening with the drive there. So we can do this for individuals, where individuals can go through this process on their own. And I should mention that we think literature shows that post-traumatic growth happens more frequently than post-traumatic stress. About 30 to 70% of the time, traumas will lead spontaneously to some features of post-traumatic growth.
Dr. Olson, your slides are not advancing.
Oh, no. Okay, let's see. I think this had happened earlier. I don't know why it is, but let's make this big. Okay, do you see this different slide?
I do.
Okay, so here's where we talk about no shortcuts. Here's where we show the trend for a disaster, moving from the baseline to the adrenaline kicking in, to then the fatigue, the triggering events, the anniversary, and then as we move into recovery. Who's driving? Is the stress driving us, or are we driving the stress? What we can do for individuals, that individuals can go through this process of hunting these domains of post-traumatic growth toward improvement. And then what can we do for organizations? Now, the examples that we found of post-traumatic growth, and we published in a JAMA article of the same topic, is, for example, the Swedish health system in Seattle. Just prior to the pandemic, they had a significant disruptive strike. And it was a crisis for them, as they described in their writings. And what they did was that they leaned into it and learned, what do we need to learn to improve this situation? And they improved communications. They improved the way they had more distributive leadership. They improved the way they care for their caregivers. And they found, because of their leaning into growth and learning through crisis and through the stress, that when they were first hit by the pandemic, that they were more prepared than they were before to deal with the crisis as they were first to be hit. And it's shown that those who have had previous traumas, if they do go through this process of post-traumatic growth, that they can also it can be protective of subsequent traumas if you were to have another. So we encourage that organizations also deliberately try to get learnings from the experience and to not leave those learnings behind, but to incorporate them into their way forward. Another example was after Hurricane Katrina, it was extremely disruptive to the healthcare system in New Orleans, to the point that to deal with this, they had to have pop-up clinics for primary care, and they put them all over the city. And those end up growing into reimagining what caring for the population would have to be, reimagining primary care, which then became a model for a national model, because they leaned into this crisis and say, this just all has to improve, and how can we improve it? So how do we do this for individuals and organizations? So it happens spontaneously, but we think that it can also be facilitated in some cases. Some debate whether a catastrophic medical diagnosis qualifies by the DSM as trauma, but we know that people who try to facilitate post-traumatic growth in these circumstances are able to facilitate it within the domains I'm about to tell you about. And that when you go through this practice, that some of those benefits can also be sustained at 1 year of doing this. So how would we facilitate it? So we would use the stress that we're feeling, and then we would look at how we've responded to the stress event. And then we would try to harvest those learnings. And we go through these domains to try to hunt them. This can be helpful if you go through these domains. In what ways, and we're going to do this for individuals and we're going to do this for organizations. And something you can do with your own group is to go deeper in more of a dialogue into these things, to talk about ways that this pandemic has brought you these good things that you'd like to hang on to going forward that weren't there before. So deeper relationships, for example. When it comes to you as an individual, it can be who at home and at work, who has rise to the occasion and been there for you when you were stressed, who came to your aid, who made you feel comforted. For example, when we first started seeing COVID-19 patients, the intensivist would come to the floor to see if a patient needed to be intubated, and they were looking out for hospitalists saying, oh no, don't go in there, we don't need 2 people in there. And now these are people who would normally may have a scuffle about whether there's indication for transfer or, something about workload, but everybody was caring for one another, and it just really was profound and deepened those relationships. Surgery was doing mindfulness meditation with anesthesia, and those two were working side by side and doing that. When people were at work and they were stressed because they wondered at the very, very beginning, a year ago, when people didn't know what the meaning of this infection was going to be, and they worried, am I ever going to see my parents again because they're across the world and can't travel and they're elderly and it's hard to make them, stay isolated, and maybe someone would break down at work, and somebody was there to really listen and then to share the experience. Hey, me too. You know what? I'm feeling that too. I'm glad to hear that we're all going through this together. And so we all have these more profound relationships with each other at work, that we saw how interdependent we are and how much we need each other. And I think we're also seeing just a lot more respect and self-compassion and empathy and interest in one another at work, which just makes the workplace so much more wonderful to be with all these other people. Plus, we saw the collaboration that was happening between all of the different groups with infectious disease and hematology, with coagulopathies and radiology, bringing together these new findings. And everyone was just working together so well as we so quickly had to learn about this new disease. And it's something that we realized is possible, and it's a potential that we can go forward. And what else can we do with this possibility? At home, though, parents were homeschooling and the kids were back in the house and everybody was together, and it was stressful and it was hard, and work-life balance was hard. But the other thing people say is, it was nice to be together under one roof for a while. It was nice to have some game nights and to have something that I didn't think I'd have again with the kids back in the house, for example. Now, how would organizations do that? Organizations took care of people by, for example, our primary care doctors, to make sure that they were financially stable, to make sure that they had everything they need, converting to telehealth. That really demonstrated to people that my organization really cares about me, and that loyalty and that relationship, really, that trust really came together through that. So these are some examples of ways you can facilitate these conversations and facilitate a reflection, but also to think, how do we want to hang on to this? What do we want to do with what we've learned? We've learned that we're stronger than we thought. And I mean, especially you have to credit nursing at the bedside all the time, with all the exposure and the fatigue. And and we have to celebrate that. We just came through Gratitude Week, which was started by our CNO of nursing, and it was just wonderful to hear people's stories coming through and to be together. Stronger than we thought, but we also all need to take care of each other, refresh each other, because now people also need to rest, and we need to find that way. But what can we do with this new fun stream? Open to new possibilities. I love this picture because it shows what our Pinterest skills can do, how it can be translated into all these bags to hang your own PPE with your name on it. The other things that we discovered is, what were we able to do, for example, at Yale New Haven Hospital, to recycle masks, to find masks, make, different types of pharmaceutical things that we need, or things that we could make in-house. And if we could do that, and if we could get telehealth and so many IT solutions in place that quickly to respond to this pandemic, what else is possible if we put our mind to it to improve the digital work life in medicine? So how can we carry that forward now that we show what's possible and what we can do, and all of those resources and all of those people and all of that talent has been exposed? What do we want to do with that? And the other things that people are open to when it comes to new possibilities is they start to reflect on, what are my priorities? As they've been so shaken up by this, and they're thinking about where they're living, who they're missing, what they thought their life was going to be, what they didn't do to date that they had planned to do. They're starting to think, how do I realign my life with my values and my priorities? And that's another thing that's happening. And sometimes people are moving closer to family. Some people are having children. Some people are getting married. Some people are finding out what is it that they didn't do that they should have done, that's important to them, that they've put on the back burner. that they want to do for themselves to start a business. We've learned greater appreciation for one another. This is transport. And as we've all been taking care of patients, all of us, whether you're food and nutrition and transport and protective services, transport is in the elevators with all of these patients, transferring them to rooms. And we found out that we're not just doctors and nurses who, you know, running healthcare, and that we're all an integrated mission. Everyone is mission critical. We find that when we go to the grocery store, that we're glad that there's somebody keeping the grocery store open. We're glad we can find toilet paper and rice and the things that were hard to find in those days, that the grocery store was open. That people came to pick up the trash, and we find out just how interdependent we are and how lucky we are and how grateful we are that we have that, and what more can we do, and how do we appreciate one another and facilitate even more, and the kind of life that we want, the kind of life we appreciate and that we want. And also with the spiritual deepening, as we find out that all around the world, we are all in this together, and that it's bigger than ourselves. And sometimes we also, that perspective also helps us to get through hard times when we see that we can't control this and it's bigger than ourselves, and that we have a purpose bigger than ourselves, and that we are in this with each other, and we rise to the occasion to take care of the patients in their time of need. And together, we're all unstoppable. So the magic solution is, how do we maintain positive emotions? That's part of what we are thinking to do, that social cohesion and sense of control. I'm gonna just stay here and talk a little bit about these. So when we can hunt the good stuff, when we can stay hopeful, when we can stay optimistic, when we have a chance to regulate our stress, and we have a chance and an opportunity to choose, when we notice that we're going negative and we have a chance to go positive, some of our optimism is predisposed, almost half of it, but the other half of it we have a choice about, and it helps us to get through hard times, of how we're going to do that. Sometimes it's the self-compassion that we give ourselves because of things aren't the way that we wanted them to be, because it's hard. Sometimes it's through the gratitude that we have to be alive or to be with each other. And sometimes we have a chance to experience the awe and to savor that which we have, are some examples. There are different types of mindsets, such as growth mindsets and perseverance, that can help us to do that as well. Social cohesion gives us a chance to share our experience and find out that, oh, we're not the only one, we're in this together, that other people are experiencing what we're experiencing, and we feel comforted by that. And we also find through that our disclosures and our vulnerability are met with care. And we also find that we can be a role model for other people, or we might find a role model in others of how they were coping, and we can take the lessons that they learned as our own. And when we feel out of control, and there's so much we couldn't control during this, it really drives our sense of stress and anxiety. And so when we find a way, either through knowing that we're okay with these folks, or that maybe there are things we can do. What can we put in place? That's one thing we tried to do, was to create a sense of control. The hardest one was childcare and homeschooling, and that work-life balance, that still remains a stressor today. But to give people a sense of control of what PPE to use, when that you will have PPE, that you know the latest algorithms, that we give you all of the support for patient care, all the training that you need. And we put it all in one place and curate it so that people feel a sense of control, that they can move within the environment, and they can get what they want when they want it on demand. We also put there supportive structures for helping with all of these things, either through our one-on-one counselors, or through our coaching, through our peer support, through our decompression huddles, our True North or Valiant groups, our collegiality groups, commensality groups, through our Schwartz rounds and town halls, and ways for us to come together to share the emotional side of work in a facilitated way that can help us to hunt this good stuff so that we can rise together and we leave no one behind. And so that if we see that someone is withdrawing or being cut off, that we look out for them, and we, with positive regard, that we look for them, and we honor their need for privacy, or if they're grieving, but we stay by them and support them. And so this also, thank goodness we had breakfast, lunch, and dinner through the pandemic without fail, because we're all interconnected. So I want to give thanks to everyone who is a part of this and around the world, and this story that we all share, that we were here and bear witness in 2020-21. So I'd love the opportunity, having introduced this topic, to hear your thoughts on it and your questions, and to have more of a dialogue. Shall I stop share, Joanne?
You don't have to. If you want to ask a question, if you raise your hand, I'll unmute you and you can ask her a question.
I should mention one thing everyone wants to hear when we talk about work-life well-being is that while I'm presenting post-traumatic growth here today, or our psychological support, all the medical community want to make sure that we don't abandon the other aspects of work-life well-being. I will just briefly summarize a little bit what those are. So we kind of think of them in the culture and climate, and we think of it as their workplace efficiency and resiliency. I'll just give you a little bit of an idea what's in those buckets. So culture and climate, I often think of leadership quality, which means that you feel seen, heard, valued, developed, that you have very effective teamwork, clinical teamwork, you're working like a team, that you have collegiality and appreciation, and that you have a sense of belonging, that you feel that you fit in and are valued and there's space for you. When it comes to workplace efficiency, we often think of the EHR, the volume of work, the flow, the pace, the efficiency of that work. And in resiliency, we often think of work-life integration, time to rest and recharge, second victim and peer support, and financial and psychological well-being, mental, physical health, and job crafting, the ability to have some ability to job craft so that you can maintain your engagement and your love of work. Medical communities want to make sure that those things are kept on the agenda.
Joanne, this is Dr. Beckford. Can you hear me?
I can.
I just wanted to thank Dr. Olson very much. I think this was an absolutely lovely presentation. And I think the part that resonated the most with me is just relationships, because I think that in primary care and in pediatrics, we have found through COVID and through other challenging circumstances that being there for each other has been incredible. And I think the way you portrayed the importance of relationships, not only in the workplace, but also in our personal lives, is so important. And I wanted to thank you for your presentation and hope that we have some other questions on the board, but really thank you. Lovely, and a job well done. Appreciate you very much.
Thank you, I appreciate that. Yes, relationships, we try to create a sense of cohesion while we are socially distancing. So we try to build that in.
Joanne, are you going to allow Dr. Marks to present his question?
Yes, I was. Hold on a moment and I'll open him up. Dr. Marks. Dr. Marks, are you there?
Yes, I just unmuted. Thank you very much. I appreciate the opportunity to hear your presentation on physician burnout. And in this time of COVID, when we have all been stressed, I know many of us have found continual board recertification and the MIPS quality measure reporting to cause even more burnout on top of dealing with the pandemic.
Mm-hmm.
And thing organized medicine can do to stop this so we can get down to doing patients over paperwork and not paperwork over patients. And I know the American Board of Medical Specialties and CMS has given hardship exemptions for at least 2020 and probably 2021 for doing all this extra work. And is there any way that you or someone else can see if quality has suffered in the pandemic by temporarily suspending these things, or do we have to jump right back in and on top of everything else we're doing, do all this other paperwork?
Yeah, I mean, we do know that the Cures Act, one, we do know that administrative complexity is definitely one of those major stressors for healthcare. And many people, the American College of Physicians has written a white paper. They wrote almost the same one twice in 1991, and then again more recently, I think it might have been 2017 or 2019 perhaps, on the white paper of strangling and red tape and the administrative complexity. And we do know there are about as many people in the back office support managing administrative complexity as there are front-facing clinical care. So that's a significant number of people who are managing that. So we know two reasons, numerous reasons why we need to get at that is because it's inefficient, it's expensive, it drives burnout, and we need to get at it.
Well, I think it's a leading cause of burnout, and particularly now is the time to address it in this time of the pandemic. And I feel like organized medicine, certainly the American Board of Ophthalmology, certainly the AMA, is doing nothing.
The AMA actually has, Christine Sinskiy of the AMA, this has been her major initiative of trying to, she talks about making the efficient cockpit, the doctor's cockpit, because it's just full of administrative complexity. And so that's kind of a metaphor that she has used. She's also been advocating both through the lobbying effort, through the research effort, to make sure that all of these EHR documentation administrative things are measured and that we keep an eye on them. We know from passing the Cures Act that people are seeing a lot more in-basket items, both with the pandemic, the Cures Act, those questions that we're seeing a lot more open notes, we're seeing more in-basket burden. And
Wait, you're saying more what? Oh, in-basket, okay.
In-basket, yeah. And so we're working on that on numerous fronts. We work with a consortium and with the AMA to advocate for improving the efficiency, or this cockpit that we work in. We do know that physicians spend 50% of their time documenting, another 30 hours a month in pajama time, and time on Saturdays, which we call date night. So this definitely has to be changed. The other thing I would like to see would be wonderful is if as we're all very mission driven, if we all focus on the mission, the patient-centered mission, that half of that group in care that aren't patient facing, that we kind of change the paradigm to see if we can make the back office more efficient to lift the load as their way of serving the patient, to clear that space for the patient care. So it's definitely a heavy lift that's going to require everyone. I think as many people that advocate, lobby, and work toward this end as possible will get there. Definitely.
Well, I tend to disagree with you. I have been very active in the Georgia Medical Association of Georgia, and nothing has really changed. I've been very involved in the American Board of Ophthalmology. Nothing's changed in the last 5 to 10 years. In fact, from my perspective, it has become worse. And so I'm spending, like you say, as much as 50% of my time doing things that have nothing to do with taking care of my patients. And I just think we're close to a breaking point with 8% of doctors shutting their practice after the shutdown, and guys like me who are 60 and 61 who are probably going to say, you know, I'm not going to continue this. I'll just retire early. And I feel like organized medicine is not listening to us in responding to helping us take care of patients rather than paperwork.
Yeah, I can bring that up again to our consortium. It's definitely high on everybody's priority, but I'll have to, do you have ideas of what you'd like to, what you do see happening and where you'd want all of the effort to focus?
Well, absolutely. I have board recertified 3 times. And I find that insane that if I don't pay my yearly maintenance fee, they say I'm not board certified. I mean, it's extortion on the side of the boards. And after 30 years of clinical practice, the clinical information that I have acquired should speak for itself. And I think you're going to find lots of doctors who just can't continue to do this in the present form, particularly when the older doctors have been grandfathered in and there's been no proven study that shows that any of it shows any benefit.
Dr. Marks, this is Dr. Beckford. I want to thank you so much for raising this most important question. And I absolutely hear your passion and fervor, and I can tell you it's not a new question. I think that just given this forum, I'm going to ask Joanne to take this to Cobb Medical Society, and I think we could work through the system to look further into this, just so that we're sure that Dr. Olson gets a chance to answer some of the other questions. But most importantly, gosh, first of all, thank you for your years of service. That kind of clinical experience is not often come by, and we thank you so much for that. But I think let's take that concern off. Perhaps you could even write to us as a system, and we could try to help you with getting it channeled. But it's a great question. I'm sure that you are the voice of many with the same concern, and thank you.
I would say the majority.
Dr. Cohen has a question. Dr. Cohen, are you there?
Yeah, this is Steve Cohen. Maybe more of a comment than a question, and it's maybe to give a different perspective on what the last speaker just said. There's no question, like from my perspective, the worst thing that's happened to my personal life since I went into medicine was going on Epic. And that's with the perspective of, I used to be involved in a master's program for medical informatics. I spent a couple of years trying to develop a medical software program. But to me, a big part of the problem, it's how doctors use it. I do general internal medicine, so I'm supposed to be aware of what's going on with all my geriatric patients when they're seeing their multitude of doctors. And you see all these doctors who do these notes that are routinely 5 to 7 to 8 pages long, and they're just pulling in all this extraneous data into their note. I've read studies showing that in Epic, doctors in Europe spend about 2/3 of the time documenting than what people do in the US. I'm sure some of this is concerns about compliance and getting audited, which, I think should be less with the new rules for charting that started in 2021. I'm sure part of it is the fear of lawyers, but when you're using the system to make notes that are kind of unreadable because there's so much information in there so that you can't see the forest for the trees sometimes, I think one, that's somewhat self-inflicted as far as making yourself work harder. And number two, from my perspective, if you think it's important to know what happens with the patient on a follow-up visit, it causes a lot more stress because it takes a lot more time to try to figure out what was going on with the patient, because you have to look through the echocardiogram that was done 7 years ago and the EMP that was done 12 months ago, as opposed to just what the relevant information is. I don't know how you go and tell tens of thousands of doctors to do things in a way that's more logical and is going to be more useful. But I think that's a big part of the problem.
I definitely agree with you. And there are, with the new notes, with the new rules of documentation, that should ease things up a little bit as people become familiar with it. You also reminded me of something that we do, because you said people don't really know how to use Epic as efficiently, and that's true. So we've started what's called Building Against Burnout, our CMIOs, and you can earn CME while you learn how to kind of craft your Epic space and your how to learn about what's changing with the Cures Act, with the new documentation, how to rearrange and shape the Epic the way you want it to be. So that's one thing we do. So we try to empower people individually to have more control over the stressors. We try to work at the department or section level for them to also have more control to do these things. And then we try to leverage our annual wellness scores to leverage the organization for which priorities are important. And we also then, as the last speaker was saying too, try to come together in consortiums that we can help, that we can move the needle a little faster than we can as individual organizations, to see if we can improve that experience. I do have one, we don't have good metrics for this, but I can show you this one slide here if you're not already familiar with it. These are some of the things Christine Sinskiy at the AMA has recommend measuring, because the total EHR time, work outside of work, time on the encounter, and undivided attention. Because when you were saying that your relationships and your work-life balance has suffered because of Epic, and we do spend a lot of time, and it's not only Epic usability, but it's the content of those things. And so I mentioned this white paper. These are some of the general principles that we want to do to try to improve that EHR experience. But these are the things that are recommended to measure, to track, to see if we're making improvement.
Yeah, my thought would be that I think that the likelihood that doctors on their own are going to change habits that have been years in the making is quite small. I think that, if initiatives such as yours actually came up with some best practices, looking at EMRs and saying, okay, this is how they are. These are the ways where they could be used in a more constructive way that would be less stressful for people, and kind of promoted that as a best practice from one institution to another, and maybe had some training on how to make these changes. I think that would be helpful.
Yep. I think EHR and the administrative complexity, that environment are both opportunities. Got to get people back to give their joy minutes back. And also people talk about team-based share the care, and to get more efficient with that as well, so that everybody goes home and gets more joy minutes.
Thank you.
Thank you.
We have another question. Dr. Gomez, did I unmute you?
I believe I am unmuted. So Dr. Olson, thank you again so much for this presentation. I am a clinical health psychologist with WellStar, so I am coming to your presentation from a very different perspective. And I'm actually working on a lot of the wellness initiatives for our team members. And one of the challenges I'll throw out there and get some feedback from you is I have a really hard time getting our physicians to pause and turn inward and take a moment to actually take care of themselves throughout the day. Did you have any challenges or hesitation introducing your mindfulness groups, and how did you overcome that?
I think I can say how I overcame it for myself, and I can say how I see it evolving at our own organization. First of all, for myself, I don't think I would have gotten or understood the benefit of it without making a real commitment. Like, I could try to do mindfulness by myself without training, but I never understood it or got it that way. When I made a commitment to go for a full weekend, not overnight, but to spend the whole day with a group and training how to do it, where you had to sit there and try, and you had a facilitator and you had somebody kind of holding you accountable, then I got it. Then I was like, oh, wow, this is powerful stuff. And the more you practice, the more powerful it is, and the more control you have to have that kind of mindfulness pause in a moment. You know you can capture it, you can go to it, but it does take practice to know what it is and to get there. So people are willing to give it a try to the extent that they know it and they know where to find it, they know where it feels like. I definitely think it's worthwhile and valuable. I mean, it's like eating right and going to the gym too. It's like you don't do it, and then when you do it, you're like, oh, that was good for me and that feels great.
Yes.
When you have a practice of it, when you're in the OR, if we may not have many surgeons here, but if you're in the OR and you hit an artery or a bleeder, you're just more present to deal with that situation. Or if you have another stress or an interaction with somebody at work, because everybody's under pressure right now. Lots of people are feeling so irritable. When we have the mindfulness to be able to pause and say, check in with ourselves, we might say, oops, that's my stress that I'm taking out on everybody else. Or we might see that irritability and stress in someone else and say, I recognize that. That person's not a mean or bad person. They're under stress. Maybe I should respond in a more kind way. Those things are helpful. I think I can't remember the author of the paper who showed the kind of compassion that you can have just by being able to tap into that. At our organization, we have some champions that just are diehard and keep it going in our perioperative mindfulness. Dr. Vijay Karup in anesthesia is one of our main leaders in this. And then the surgeons signed up, and having role models and having people who are like, oh, that person is trying mindfulness meditation, and they make it so comfortable. So you can go there and be curious. You don't have to know anything about it. You can just go there and be curious, give it a try. and gives you a chance to be with other people too. And it's a break from the mundane and the routine, even though people feel like they don't have a second to waste. They don't have another minute. They're trying to get their joy minutes. The last thing they want to do is add something else. But they have to try it to know how to make a decision for themselves of the value. So I would say that.
Thank you for that perspective.
Dr. Tharp has a question. Dr. Tharp, are you there?
Yes, can you hear me?
Yes, we can.
Wonderful. And thank you so much for your presentation. I've enjoyed the entire hour. I serve as the chief of the primary care and medicine service line, and have Dr. Beckford's counterpart for adult medicine. I think that what you've mentioned about the mindfulness meditation and just following up on that is a really key aspect that we sometimes ignore in the burnout situation. And we talk about, I think one of the most frustrating things I have learned over the years when people refer to the computer time outside of work, which we'll probably all be doing tonight, they're referring to it as pajama time, as if it is some romantic Norman Rockwell painting instead of the existence that it is somewhat frustrating.
Yeah.
But it brought to mind a little bit about what all this does to us and how it interferes with what drove us into medicine. And I think that it's worth saying that so much of what we have lost is time to think, because all of us went into medicine. I would say 99% of people who go into medicine look at it as a way of making decisions, managing information in ways that may not be obvious. Years ago, when I first started this medical journey, I was intrigued by a book by Burton Rouchet on the Orange Man, or there are stories of medical detectives, and how we think through problems at an early age probably led me into internal medicine just on a personal basis. But not long ago, we had a primary care physician who retired. He was an octogenarian, and he was telling me the story of one day, actually on his afternoon off, going fishing. And while he was sitting out on the lake, it hit him as to the source of a patient's problem, which was a food dye allergy in one of the medications he had prescribed. And just that visual of seeing him on the lake with putting that together and having that time to think, and how that is really no longer a part of our existence, really kind of honed in your comment about the mindfulness meditation and how we can use that to recapture some of that time. It's not easy. And time management is not easy for anyone, but I feel I just wanted to add that comment that, taking away that thinking time is really probably one of the things that we regret the most as physicians.
Yeah, absolutely. And I love your description of the rest and relaxation allowed the answer to come out as the mind was sorting through things. And we are complex, we're high stakes, complex decision makers. And that's also why with leadership styles, we try to go to contingency management style, where you make sure to get the input or of those high stakes, complex decision makers as you lead, and to make sure that everybody's input is there because of the responsibilities that they have of working with professionals. And I agree that we need to decompress the thinking time. We need to decompress the space and the interruptions. We measured the administrative task load. In the past, we've measured the mini-Z, hectic, chaotic workplace. Those are definite strong drivers of burnout. Those are things that we try to identify, our high opportunity work units, and we try to address those very specifically, and we try to drive those measures down, absolutely, for those reasons. The other thing it reminds me of is sleep. Also, sleep is so important for the coping, and it's another thing that we think we can get away with. Through our training, we've been used to pushing ourselves so hard. And sleep is also that time where we are consolidating all of that information and we're sorting out and solving these problems. It also helps us with our regulation. It works at the amygdala and our irritability, and just to prioritize sleep, to just make sure that we make it a priority, because we are so used to pushing ourselves so hard to get so much done, and we can deprive ourselves to do things, but sleep is one I wouldn't deprive, and for that very same reason as well. And it reminds me of one more thing, and that is some of the work that's been done all the way from Dr. Donna Bedian when Medicare came into play, and we talked about the quadruple aim and who determines quality and value and metrics and who pays for what. You know, we've had this debate for a long time, and some of the modeling of physician well-being is that you have the ability to make complex decisions. You have the agency within your practice to be in service to your patient to get a safe, high quality result that you're both proud of, and that therapeutic relationship is sealed with the result that you're looking for, that you've agreed to. And that's kind of a basic model of, you know, what we'd like to accomplish. So clearing out all that cognitive load, that noise, and that complexity, and that hectic chaoticness definitely is a goal. Not an easy one, but a long-term, relentless commitment.
Dr. Olson, I want to thank you. This is Dr. Beckford, Avril Beckford. I know that we're going over time, but I feel like the questions from the physicians and the way you've answered them has really taken the entire talk to a new level. Just your ability to listen and connect. And I think that's one of the greatest values from your talk, is when we're hurried and when we haven't slept enough, we don't take time to actually stop and breathe and listen, truly listen and hear the patient or each other. So my take-home messages from your talk are manyfold, but the most important thing is in crises, and we've certainly faced a number of them recently, are to take a deep breath, to be sure to listen and connect. And I think that even the surgical timeout is probably from, you know, and Atul Gawande's work is a shining example of just perhaps we need to take the checklists we do, but also add to that a personal moment of meaningfulness and taking a breath and truly connecting and being in the moment. So I'm going to defer to Joanne, because I don't want to take too much of Dr. Olson's time. But Joanne, I was thinking that we might, if there are any other questions, have those forwarded through CMS. But I wanted to thank Dr. Olson for what I think is a very meaningful and helpful presentation. And I want to thank all of the participants who either questioned or wrote in on the chats for their participation. Joanne, did you have any extra comments, or Dr. Olson, any additional comments?
I just want to thank you for having me. It's just been wonderful to be with you. It's just an honor, and I appreciate all the questions and the dialogue that we've been having. Thank you so much.
Dr. Olson and